if this exact same symptoms were presented in a person living without obesity, what would I be ordering? And if the answer is different, that's my flag to slow down and to look at things differently.
Hello and welcome to the Scale Up Your Practice podcast brought to you by Obesity Canada. I'm Dr. Roshan Abraham, family physician and associate professor at the University of Alberta.
And I'm Michelle McMillan, a lived experience advocate with Obesity Canada.
A patient living in a larger body presents with fatigue or shortness of breath. The immediate reflex in healthcare is often to attribute those symptoms entirely to their weight. But what are we missing? Diagnostic overshadowing means we frequently underscreen for the actual complications, like sleep apnea, MASLD, or cardiovascular issues, that we would actively investigate in other patients. Today we're talking about how to use evidence-based screening tests to identify obesity-related complications more accurately and confidently.
Today's episode is sponsored by an unrestricted educational grant from Eli Lilly Canada. We thank them for helping us bring this podcast to clinicians across the country.
Today, we're focusing on interpreting screening tests and integrating the best available evidence into clinical practice. Specifically, we want to help you address knowledge gaps when it comes to identifying obesity-related complications.
To do that, we are joined by Dr. James Kim, a primary care physician with a dedicated focus on chronic disease management and clinical education. Welcome to the show.
Well, thank you very much for having me, Michelle and Roshan. It's a real pleasure to be here.
So I guess the first question is, why is this such an important topic for clinicians right now?
Yeah, a very good question. So this is probably one of the two biggest topics in medicine right now, along with menopause. So I guess that also explains why obesity in menopause is a real hot topic right now as well. And I believe that it is because of the three main reasons that I could think of. The first of all, the science in obesity medicine has moved really fast, probably faster than the how amoeba changes its morphology and its shape. And that's really fast. And so much is happening in this space. And we have more tools than we used to have before, which used to be just lifestyle modification only. And I believe it is by far the most difficult management strategies that the patients can adhere to. But we have more tools available. But also, more importantly, we now understand that obesity as a complex chronic relapsing disease, not a lifestyle choice that has failed. And it is not about how we look outside, but there are over 230 potential complications or health issues associated with obesity, and definitely deserve the same rigorous screening that we give to other chronic diseases as well. But finally, and most important reason, I believe, is that the people living with obesity are advocating for themselves, which is probably one of the most important things that they can do. And huge kudos to them for changing the landscape of obesity medicine.
So chronic disease management is a huge part of your clinical focus. What made you start noticing the gaps in how primary care physicians screen for complications in patients living with obesity?
So it really started by reflecting my own practice, which wasn't very good at screening people with the obesity complications. So when I graduated and from my medical school and residency and became a family doctor, I realized very quickly that cardiometabolic disease is everywhere. We cannot get away from it. And I was actually very bad at it, especially when it comes to diabetes. So then I took a 2-year postgrad diploma in diabetes, which really opened my eyes to what needs to be done to reduce the illness, the complications, while improving the health of my patients and improving their functions. So following that, I was fortunate enough to be part of the national guidelines in terms of writing the guidelines, leading them, and disseminating and implementation of those guidelines for diabetes. So this experience really helped me to focus on ensuring that the complications need to be properly screened. So these moments were more like a duh moment where the light bulb suddenly came on. And it's almost like, how in Matrix, when Morpheus gave the pill to Neo, I trust you all watched Matrix. Yeah. And when Neo took the pill, he began to see the reality. And once you see the gap like this, you can never unsee it. Then I started implementing these proper screening algorithms for obesity and diabetes related complications for my patients. Then I started noticing improvement in my own patients' health and began to see more gaps in primary care in obesity related complication screenings or lack thereof. So it really came from examining my own deficiencies. I still have deficiencies. I'm improving them. But that's how I came to know that there are some gaps in private care for sure.
And I think that is amazing to hear, especially with the shift from earlier in your career to later in your career. As a primary care provider myself, that self-reflection process and really ensuring that we're staying up to date with the evidence, especially with chronic diseases that are changing so rapidly. And let me just say, your analogies are spot on. I don't think we've had anyone on the podcast yet who have pulled out two analogies like that, amoebas and the Matrix. I have to say that is quite impressive.
There are more coming.
Okay. So let's talk about the realities of limited time and resources in primary care. The guidelines recommend specific baseline tests like HbA1c, lipid panels, and ALT for MASLD, which was mentioned previously, but for those that are listening, metabolic dysfunction-associated steatotic liver disease. How do you use those recommendations to screen for metabolic complications in a way that's practical in a busy clinic?
That's a great question. So first of all, I mean, even as a person who wrote the guidelines and still writing some guidelines from in the different medical fields, and also knowing that the guideline is very much based on the science, I can tell you that the guideline is there to guide you, is not telling you that this is exactly what needs to be done. And it's really up to the healthcare professionals to adapt the guidelines to their practice and their environment and figure out what works best for their own place of work. And guidelines only helps us if we can actually adopt it and operationalize them in our 10 to 15 minutes of the visit. So what I do is that I built a standardized baseline panels that I order proactively at an appropriate intervals. And I do really want to specify a word, appropriate intervals, which means that we don't have to do these tests in every 3 months or 1 month or so. Anyway, so by having this kind of a standardized baseline panels in my EMR, it isn't something that I have to remember all the time in the room because, as you know, Roshan, sometimes it can get really hectic, and I don't have time to actually use my other brain cells actually and try to get these complication screenings. So for the adults living with obesity, the typical things that I look for will be the very common ones will be like a pre-diabetes and diabetes by ordering A1C. Now, I don't really see the point of ordering fasting glucose for almost all of our patients. But the association between diabetes and obesity is very, very close. So I do screen for diabetes very closely. Full lipid panels, including ApoB, LP-little-a, and hsCRP, I do them for cardiovascular risk stratifications. And as you know, LP-little-a and then hsCRP probably just needs to be done just once in their lifetime, at least for now. Things may change down the road, but at least for now, yeah. TSH, vitamin B12, ferritin, because these deficiencies and thyroid disease can be quite common in our patients and be easily missed. Blood pressure measurement with an appropriate sized cuff, very important, because otherwise we're not going to get the right results. Now, I love Obesity Canada, and I love I love Sean Wharton, who kind of oversaw everything. But I do have one issue with using ALT, and I know that Obesity Canada is very well aware of the fact that the ALT using ALT to screen for MASLD is an old concept, and we don't do that anymore. And going back to the evidence, some studies are actually showing that even up to 80 to 90% of the patients with MASLD actually have normal ALT. So we are going to miss it a lot. And I know Obesity Canada is aware of this and they're looking to change it. So what we recommend is that we recommend using this calculation called FIB4 test to screen for MASLD-related liver fibrosis. So the first thing is that do we actually even have to screen MASLD in people living with obesity? The answer is no. And we took a similar approach in Diabetes Canada as well, because 70% of the people living with type 2 diabetes actually have MASLD. So what's the point of screening for those conditions that they probably have already? And besides, just having a fat deposition in the liver doesn't really lead to any meaningful outcome. Because it's not the actual amount of fat deposition in the liver. I mean, there's some data that will say it is, but it's actually the liver fibrosis that determines the patient's outcome, like increased risk of MI, stroke, cardiovascular disease, renal issues, and also liver-related complications. So it really has to do with the liver fibrosis. So then we would use a FIB4 test to determine the likelihood of the person having the non-significant liver fibrosis, or do they have a significant fibrosis? So we came up with the guideline in Diabetes Canada, so MASLD in people living with type 2 diabetes, which I was very fortunate to be the lead author for. And we have a whole guideline and algorithms on FIB4 test, and I believe it can be adapted in people living with obesity as well. Then there are some other conditions that I definitely screen for on regular basis, at least once a year, that I think that gets missed in many of primary care when managing people living with obesity. So these things could be the mood disorders such as depression, anxiety, PTSD, eating disorder, especially binge eating disorder. This gets missed so many times. And if binge eating disorder is not managed, then I mean, good luck trying to manage their weight too. Obstructive sleep apnea, obesity hypoventilation syndrome, which is far more common than we think. Sleep disorders, because things like insomnia can really impact on one's weight, but also massively in almost every single cardiometabolic conditions that you can think of. Some of the vaccine preventable diseases. So these are some of the things that I usually screen at least once a year, if not once every 2 years. It's almost like a diabetes flow sheet approach that we have in Canada, but applied it in the obesity-related complications. In that way, that we can screen our patients in systematic fashions, and not just trying to remember at the moment when I see the patient. The Canadian Adult Obesity Clinical Practice Guideline is excellent, and it gives us a really good framework, and we just have to build a workflow around this whole guideline.
So you mentioned the blood pressure cuff, right? So that speaks as a limitation, right? And we know that there can be limitations to equipment and access barriers for patients living with obesity. So in your opinion, how should clinicians think about screening when those limitations affect what testing is possible, maybe how reliable the test is? How do you recommend to our listeners to deal with that situation?
I mean, that's a really good point and very, very important question, Michelle. And I think this is a topic that is often under-discussed because it's not considered as sexy as talking about newer medications. And there's also the real barrier from the cost perspective as well. So I personally run a medical clinic, so I am a bit privy to the equipment barriers and the cost associated as well. But we also have to remember that lots of our diagnostic tools were designed for people with the lesser weight or narrower body size range than the people that we actually see. So there's some practical things. So blood pressure cuffs, if it's too small, then you're likely to get more falsely elevated readings. So you can have a extra large cuffs in every single rooms, or if they don't have it, then at least if it's difficult to get the extra large blood pressure cuff in every single room, then at least have one that can be detachable in the clinic, and we should be using them without any problems. Now, imaging can be a bit tricky because the standardized ultrasound can reduce the sensitivity for detecting MASLD if we are actually going for the actual diagnosis of MASLD using an ultrasound. And it really depends on the body habitus as well. And now, for MASLD, sometimes some patients will need a fibroscan, which can be quite expensive little toy. because it costs in the region of $150,000 plus, and it can be very essential equipment to correctly analyze our patients' liver health for MASLD. And we cannot even send our patients for FibroScan because there are just not enough of them, and they're not being covered by the provincial healthcare plan. So many patients land up paying for like $100 to $150. So that is a problem. We just have to know which radiology companies or places near your areas are very good at interpreting the ultrasound in people with the larger body habitus. Scale and exam tables are something that I think very, very important to know some of the barriers around it. So knowing your clinic's weight limit and being transparent with patients about where they can be safely accommodated is a part of a respectful care. But also as a clinic owner, I do know that the scales and the exam tables that can accommodate some of our larger patients can be very expensive too. Mm-hmm. So there can be a limiting factors. Phlebotomy can be tricky because in some patients, it can be a bit difficult to draw blood. So we have to be very mindful of sending our patients to the lab because last thing you want them is to send their patients to the lab and get told that because of their body habitus, they cannot draw the blood. But yet we do know that we have to do the test. So just be very mindful of this as well. And I always frame it that this is a technical issue. It has nothing to do with you at all. So then they don't get body shamed as well. I mean, there was a very interesting story out of Stanford in their sleep clinic where this person living with obesity, over 600 pounds, apparently broke their toilet seat. It is very unfortunate that it happened, but there was a good moment to realize that we may have to have a bigger toilet seat or the toilet seats that can accommodate people with the larger body habitus. So that is something that I think all the clinics should start considering if they don't have that. So the bigger point is that when the test has limitations, we should say so in the chart and adjusting our clinical reasonings. And not just accept that the potential false negative result and move on. But also there is a barrier that it's not easy to convince the clinic owners to purchase these expensive equipments, and understandably so because of the cost. But maybe having one equipment at a time purchasing could be an option too.
So if we talk a little bit about diagnostic overshadowing, because as a person who lives in a larger body, who lives with obesity and has friends and family who do as well, we all unfortunately have a story about that, right? That obesity is the one, and our body weight is the one and only thing that causes all problems in your life, apparently, which we know isn't true. It just isn't. So I'm wondering, how you deal with that kind of thing and how you would recommend to our listeners to deal with how do you step back and go, because I know doctors, you're looking at the big picture and what's the most common answer, right? You're not looking for the zebra, right? So trying to deal with that, how would you recommend to our listeners that they just divide between the two, right? Not ignoring the zebra, but, considering it.
Yeah. No, I mean, a very good point. Unfortunately, diagnostic overshadowing, in my view, is one of the most consequential forms of weight bias in medicine. And mainly because it doesn't feel like it's a bias to us, right? And it feels like there's a clinical reasoning behind it as well. So for example, if the person comes in with a shortness of breath, and in patients with a lower body habitus, we would think, it could be asthma, it could be anemia, cardiac issue, PEs, deconditioning, anxiety, and we can go on with a list of all these potential diagnoses that we were supposed to regurgitate in our medical school. And we do investigations accordingly and manage them accordingly. However, in people living with obesity, the cognitive shortcut often jumps straight to, this is all about weight. It's a weight issue. And once that anchor is set, we stop generating other hypotheses and differential diagnosis like we would do in people living without obesity. And we don't order the appropriate investigations, such as spirometry, echocardiograms, or whatever it may be. And because we don't look into this and just blaming everything with obesity, then we don't often ask about the other issues as well. It's like I actually grew up in South Africa. As you can tell, I'm very African. I am. I often say that I am South African trapped in Korean body that happened to have a Canadian passport. Anyway, so in South Africa, the prevalence of HIV is so common. So anybody that comes in with cough, we say, "Oh, that's probably TB, tuberculosis," which is unfortunately not the case. But I think it's kind of similar thing. The result of is that the patient living with a larger bodies have heart failure diagnosed later. Sleep apnea or the asthma, COPD is diagnosed later. Cancer diagnosed later. And the literature on this is very clear. And it is not the clinician that doesn't care. It's that the differential diagnosis have been prematurely closed. And we decided without appropriate investigations when needed. So what I do is that I ask myself, if this exact same symptoms were presented in a person living without obesity, what would I be doing? What would I be ordering? And if the answer is different, then that's my flag to slow down and to look at things differently. One of the best advice that I got when I was in my young career is that whenever you see a person coming in, always think of at least 3 differential diagnoses. So number 1, what is the most likely diagnosis? Number 2, what is the second most likely? And then the third one is what is the likely diagnosis that can kill the person right away? And that really helped me so much even till this day.
Thank you for laying that out, especially for our primary care listeners who understand the challenges of generalist practice and undifferentiated patients and how bias can influence our decision-making when we see those patients for the first time. For our listeners, if this episode is bringing up questions about how to strengthen your approach to obesity care, I'd encourage you to check out Obesity Canada's Caliber course. It's an accredited course built for healthcare professionals who want practical, evidence-based tools they can use right away. Caliber includes a mix of self-paced learning and live interactive sessions, and the next cohort runs September 3rd through to October 7th. You'll find the link in the show notes, and if you're watching on YouTube, you can scan the QR code on screen to learn more and register. Getting back to our conversation, for the busy clinician listening, Dr. Kim, what does this look like in a standard assessment? For example, how do you decide when to order an abdominal ultrasound, let's say, for MASLD, liver disease in general, or a sleep study for apnea?
Yes, no, that's a very good question. So because everyone's busy. Primary care is extremely busy. As you can tell, I was running late for this podcast. Oh, can you please remove that from the recording? I'm kidding.
We'll see. We'll see if we can edit that in post. Yes.
Yeah. So I have, so for example, I have those standardized lab forms that I go through once a year. But I just want to talk more about those 2 concrete pathways for the conditions that you just mentioned. So MASLD and OSA, so obstructive sleep apnea. So for MASLD, as mentioned, we don't screen MASLD anymore in people living with obesity. We assume that they have it. The question is, do they actually have liver fibrosis or not? And as mentioned, we don't use the ALT anymore as a screening tool for MASLD. Mm-hmm. We use a FIB-4 test to see if they actually have a liver fibrosis or not. So as you know, the FIB-4 test requires 4 data points, including ALT, AST, platelet, and patient's age. And if you have a low FIB-4 score, so that's a 1.3, and that reassures me that there's a 95% likelihood that your patient that has a FIB-4 less than 1.3 does not have a significant liver fibrosis. So we can just manage them from the cardiometabolic perspective in our clinic. Now, if the FIB-4 is too high, in other words, 2.67, then the person requires a referral to GI or the hepatologist, and we probably will have to do some tests in between as well. And if the score is in between, so between 1.3 and 2.67, then they should get an additional test done, such as an ELF test or shear wave elastography. So now I just want to give you a bit of a tip on remembering this FIB-4 number. So only number that you have to remember is actually 1.3. So if it's less than 1.3, don't worry about the liver fibrosis. Just manage the cardiometabolic issues as you see in front of you. Now, if it's too high, then it's 1.67. So, but I said you have to remember just number 1.3. So all you have to do is take 1.3 times by 2. Then what do you get? You get 2.6. But but then it's actually 2.67, right? So then what I do is that, okay, so what do the teenagers say when they hear number 6? 6, 7, right? It's so annoying. But it is such an easy way to remember. So if you think of it as a high number, see, you'll remember this now forever, right? Whether you like it or not, you will remember it. So one of those things, you hear it and you can never unhear. So then you get a high number times by, 1.3 times by 2, 2.67. So that's the number that you remember. So so that's what I would do. And also just something to just remind you is that abdominal ultrasound can determine how much steatosis there is and rule out other liver pathologies, but it does not stage the liver fibrosis. So I wouldn't rely on that alone to diagnose someone with the liver fibrosis. Now, for sleep apnea, so I screen them with a stop bang questionnaire. It's a quick, validated questionnaire. And I also ask their partners about their witness apnea or loud snoring. By the way, do you know that snoring can even reach up to 72 decibels in many patients? Now, 72 decibel is really loud. It's like really loud.
Really loud.
And unfortunately, your partner will have to listen to that on average about 50 minutes per night. So that's a big problem. So your partner will probably know if you snore quite loudly and if you stop breathing as well. Then you can also ask them about the next day functions. So daytime sleepiness, morning headache, and then all the other things like uncontrolled hypertension, atrial fibrillations, all lower my threshold significantly. Stop bang score 3 or more can really increase the red flag and trigger referral for the sleep study. But then we also have to think about insomnia because insomnia is hugely associated with the cardiometabolic issues. We know that if you don't sleep well, that means either too little, too much, then your weight is likely to go up. But not just your weight. The diabetes is going to get worse. The cardiometabolic issues, development of atrial fibrillation, heart failure, stroke, kidney disease, MASLD, they all tend to go up quite significantly. So I use a questionnaire called Insomnia Severity Index questionnaire, which is a simple 7 questions. And it's very well validated questionnaires. Now, if you don't have time to do Insomnia Severity Index questionnaire, then I would ask patients 2 questions. First question is, how's your sleep? And second question is, are you still tired the next morning? So these questions are looking at the quantity and quality of sleep. And these are easy questions to ask patients and just rule out if they have any sleep issues.
So that kind of leads us to the next question. So you do the screening and it really it reveals, a new complication. In a world where the 3 of us on the podcast know this, but I would say in society they didn't in general, that people think that they have 100% control over their weight, right? It's a myth that's there and out. So if you have a patient who thinks, they're living in a larger body, they think it's entirely under their control, and now you've presented a new complication or comorbidity or something like that, how do you talk to your patient without making them feel stigmatized or biased or a lot of guilt about, I did this all to myself kind of thing?
Yeah, no, very good question. So, first of all, I always tell patients why I am sending them for certain tests and what we are screening and what we're looking for. And I really try to frame that this is a medical conditions that we're looking at. Therefore, when the complications get picked up, and it doesn't come as a surprise to many of my patients. And I think the words really do matter when these complications or the comorbidities gets found. So I once again try to frame the result as an information about their body's biology, not a verdict on their behavior. So instead of saying that your liver is fatty because of your weight, and you really need to work on that, I would say something like your blood work is showing that there's some changes in your liver that we see in a condition called MASLD. It's a very common condition. It is treatable. And the good news is that we caught them early, so let's talk about what we can do together to protect your liver going forward. So once again, really, really focusing on the fact that this is a biology that we're looking at and the health that we're after, not just talking about and being judgmental about their behaviors. Now, there's a few principles that I apply when I talk about these comorbidities. First of all, I would name the conditions. So it gives a dignity by calling it what it is. And so for things like a MASLD, by the way, don't use its old terminology, non-alcoholic fatty liver disease anymore, or we will say, oh, it's a fatty liver. So the terminology actually got changed a couple of years ago, and it took like 2.5 years, I think, over 200 experts around the world to change the word from non-alcoholic fatty liver disease to metabolic dysfunction associated steatotic liver disease. And one of the reasons for that is to remove the word fatty, to really show that this is a metabolic condition of the liver and that is nothing to do with the patient's weight. So, and also we offer what we can do rather than here's what you need to do to fix the problem. So more as like a partnership, and also acknowledge the emotional weight of the new diagnosis as well. So I would pause and let them respond and give lots of time to ask questions as well, because I think we are very good at throwing out the names of the medications. Hey, this is your new diagnosis, and these are the pills, or these are the things you have to do, without really giving them chance to think about this and so on. Or sometimes I give them an open invitation that if you have any questions, then please do not hesitate to reach out to us and we can talk more about these conditions. When I started out doing so I run a vascular risk reduction clinic in Calgary. They come in and we have lots of diagnosis, complex patients. And in the beginning, I was like, you know what? I want to save the government some money by making sure that I can tell everything about this disease on visit number 1. So then they don't have to come back, and I save them time, and I think that would be really good. What I realized that the number one, there's a bit of a cognitive overload when you do that, and patients will not get everything. And if they forget some of the things, then you blame you're not paying attention to what I was saying. No. And there is also an emotional weight of the new diagnosis. We really have to appreciate this from the person on the other side's perspective.
I'm really, really glad to hear that. And I think there's recently a change just in the last few days of PCOS, right?
Yeah.
Being changed to PMOS to represent the broader diagnostic criteria. It would ultimately fall a lot on the presence or absence of cysts that would rule in or rule out the diagnosis, when there are actually several different criteria in which to diagnose PCOS. And yet I think that shift more broadly across the medical world is really important, just in the language, especially when we see it established by organizations. I mean, the Lancet is where it was published, right? So this is really important, not just at the local level, but also at that sort of those larger levels, at that systemic level as well, for patients to understand that we're trying to combat stigma wherever it actually resides.
So Dr. Kim, you've been really good at talking about your patients, and you talked about blood work and the anxiety it can cause around it, and the anxiety around diagnostic tests. Especially if you're worried that your weight is the reason this stuff is happening, right? And I'd like your thoughts about using evidence-based screening to validate symptoms without kind of introducing that bias to patients. Because I think most practitioners aren't interested in making their patients feel bad about things, but they don't know quite how to breach this diagnostic testing in a way that will make their patients understand the reason and what the next steps are. So if you had some advice for our listeners, that'd be fantastic.
Yeah. So what I hear from the patients almost universally is some version of, it's the first time that I feel like my doctor is actually listening to me, my symptoms instead of just my body. And they really, really, really do appreciate, the evidence-based screenings really well, and to validate the symptoms, because like we said earlier, we don't just say that this is all because of your weight. No, there are actually medical issues that is going on, and patients really do appreciate that. And I think sometimes we are a bit scared that the patients will be offended when we talk about these issues. But I want to give you one example. It's a real case of this one patient who was quite obese, and everybody could tell that he was obese. But then not just that, but he actually looked like a gangster too, with a hip hop style jeans, a baseball cap, and gold chain around his neck as well. Anyway, so he has obesity. I followed my principle of how I manage people with obesity, screened him for all the complications and so on. And some of them were comorbidities, I should say, and they were found. And then he looked at me while I was talking all about this with a very serious face. He's that type of person that if he asked me for money in the middle of the night, I would give him that plus my car key. So he's like that type of person. So then when he was looking at me very seriously, I was like, geez, I'm in trouble. And then he came right up to my face and he said, "Thank you, Dr. Kim," because he said, "You're the first person that actually told him that he was obese." And by talking about his potential comorbidity screening for these comorbidities, he actually felt like he was respected and treated like a human being, not because everything was about weight. I'm sure they were related, but these are medical issues. So he knew that he was obese, obviously, but no healthcare providers actually talked to him about it, and he was very, very appreciative of that. And ever since then, I changed my attitude, and I became a lot more confident when I was talking to patients about the screenings and about the obesity itself. Because if you're fearful, if you're so worried about talking about these things, believe me, patients will pick that up. They can sense that you're not confident and you're scared and you don't really want to talk about it. And then the barrier can build up very quickly. So I would say just be confident and just say that these are the medical things that we are looking for. So it's not how they look, it's actually what's happening that we are really, really want to take care of their health overall. And I had patients tearing up in my room, not because of the diagnosis, because actually someone finally took them seriously. So that tells you everything about how often the opposite happens in our medical community, unfortunately. But, we can make lots of differences in these people by respecting them for who they are and treating them like any other human being, regardless of how they look.
Wow. That is a great note to end our discussion today. I mean, one of our themes around here is compassionate care, right? And what you've described is compassionate care. And, if we can pass that on to our listeners on how to communicate that to their patients, that is invaluable. And I so thank you for giving us your time today and your wisdom. And the Matrix reference is really good too.
So many analogies.
What about 6'7"? Come on, 6'7".
And 6'7". Okay.
Yeah.
True.
That's endless.
I don't know. Even I'm going to remember that. And that has no value in my professional career whatsoever. Thank you so much.
You're welcome. Well, thank you very much for having me.
So today we covered how to apply evidence-based resources from the Canadian Adult Obesity Clinical Practice Guideline to accurately select and interpret screening tests for conditions associated with obesity.
We also discussed how analyzing these results allows us to address knowledge gaps and how avoiding diagnostic overshadowing actively reduces weight bias in our clinical assessments.
You can find direct links to the Assessment of People Living with Obesity chapter of the guidelines, including the specific laboratory and diagnostic testing tables mentioned by Dr. Kim. So we don't have to remember the numbers. They're there. They're in our show notes. Please visit them to dig deeper into the evidence.
As a reminder, new episodes of Scale Up Your Practice drop every second Thursday, so make sure you are subscribed so you never miss an episode.
If you found value in today's conversation, please take a moment to rate and review us on your favorite podcast platform. It helps other clinicians find this podcast and join the movement.
And until next time, stay curious, stay kind, and keep scaling up your practice.
This podcast is intended for informational and educational purposes only and does not constitute medical advice. The content shared in this podcast should never be used as a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of a qualified healthcare professional with any questions you may have regarding your health or a medical condition. The information and treatment discussed in this podcast are based on Canadian guidelines and approved practices as of the time of recording. If you are listening from outside of Canada, please consult your local healthcare professional to ensure compliance with your region's medical standards, guidelines, and recommendations. The creators of this podcast disclaim all liability for any decisions or actions taken based on the content discussed. Listening to this podcast does not establish a professional or patient-client relationship.